Good afternoon and welcome again to another episode of ESOC TV. I'm Alistair Ware, I'm a neurologist from the UK. I'm joined by my other host today, who's Mira Katan, on the far left from Switzerland. And we're joined by our two interviewees today, Charlotte Cordonnier from Lille in France and Will Whiteley from Edinburgh in the UK as well. You just watched the plenary session, I hope, and so congratulations to all the award winners, particularly Professor Karzo and Professor Turk, but also to the winners of the Angels Awards and the other awards presented today. We're going to discuss the highlights from the scientific presentations today, and that's what our experts are here to talk about with us, and I hope you'll listen on and follow. So to start with, we'll talk about the first study we heard today, which was the Interstroke study, and I think I'm going to direct my first question to Will. Will, from your perspective, what did you think the main implications and interest was from this study?
Yeah, so clearly vaccination is a potentially important way to prevent stroke. And so what we've taken from this study is that there's a plausible effect on reducing stroke incidence from vaccination against influenza. And there's also a plausible increase in the risk of stroke from having a febrile illness. And that's plausible because we've seen it in other studies. And it's relevant to us just now, towards the end of the pandemic, because of the effects of COVID. So clearly we've all been worried about the risk of heart attack and stroke after COVID, where we've seen kind of quite early high risks. And we are also kind of optimistic about the effects of vaccination on reducing those incidences. And we've seen in data from the UK, perhaps a 20% reduction in the risk of stroke from vaccination. So it's all quite plausible, but we're all at the moment based on observational evidence. So we need more randomised evidence, I think, Alistair.
I agree. And in the study, as you say, it was a case control study. How reliable do you think the findings were? I mean, you said, as you noticed, there was an association both with the risk of a recent febrile illness on asking the patients whether they'd had a recent febrile illness, and also this odd association for ischemic stroke, but which seems to go in the wrong direction for hemorrhagic stroke. So what did you feel about that?
Yeah, well, of course, vaccination itself has got, and also infections have got all sorts of odd confounders.
Yeah.
So when you're having a vaccination, people who are vaccinated tend to be well people compared to people who are unwell, but also people who are relatively unwell at the time of their vaccination are also well. And so you start to see quite implausible effects of vaccination on overall mortality, which probably aren't true. And you probably can't get rid of those with statistical methods. You can get rid of it to an extent, but you still end up with some of that confound. And we've seen that quite a lot in the vaccination studies in COVID.
Yeah, and there was a 50% reduction, I noticed, with vaccination in this study, which seems quite a large magnitude of effect.
Well, it is large, but it's promising. So if we look at meta-analyses of randomised studies, which have come from the group in PHRI, people who are randomly allocated to flu vaccination have a roughly 25 to 35% reduction in the incidence of vascular events, but there's a lot of heterogeneity between studies, and a recent randomised trial in people with heart failure from the same group hasn't shown an effect that's significant in a heart attack and stroke.
Yeah. So more randomised evidence that vaccination is a good thing?
Well, I don't think we're going to have much more randomised evidence, but we can probably all agree that having a vaccine against flu or COVID is good for all of us.
Thank you very much. I'll hand over to Mira.
Yeah, so we also had really nice studies on genetics and epigenetics. So stroke genetics informs drugs discovery and risk prediction across ancestry, a large undertaking. Really, congratulations to these great efforts. And I think, it's important to see that these big data and these collaborations are possible. And, maybe Charlotte, what's your take-home message on that nice study? So.
Thank you, Mira. Yeah, you're right. I mean, my first take-home message is that collaboration is possible. And in fact, collaboration is extremely needed in this kind of field. And the genetic group have always paved the way to show us that it was necessary. It's quite impressive for a clinician to see that they have data on 1.5 million of patients on one side and 1.2 for the replication. Quite a challenge. Well, why I take from that is that there are two things that we would like to see. First, a polygenic risk score, and we understand that it's not ready yet to to do that in our clinical routine, but more importantly to help us to better identify the drug we should invest on. What I'm still not sure is that does it mean that if you do not have any genetic clues about this drug, you should stop studying it? I'm not so sure. But if you have positive finding, then you should probably more invest and try to understand the biology that is below. And also, I think one thing that has been shown is that we look at the population where we have the data, so mainly Western high-income country, and we desperately need data from low-income country where there's probably a less infrastructure to develop biobanking, and we desperately need that because this is the population that is the most at risk for stroke. So how do you think we can manage to extract the data from high-income communities to the low-income communities in this search of approach?
Yeah.
Will?
So I agree, Charlotte. So we do need much more information from those communities much more affected by stroke, which includes communities in Central Asia, in Southern Africa, all of which are very different places. So we can't think of them as one regional conglomeration. Living in Ethiopia is very different from living in Nigeria with different kind of people. So we need to think about all these large countries which are going to be the major challenge for stroke medicine, I think. And taking that lesson, I think what you've spoken about, Charlotte, of collaboration, data sharing, which really genetics has led the way, is something we probably need to do much more in clinical medicine.
Yeah, I think also we can really learn a lot from them in that perspective as well. And
yes, I think the other thing that we've learned there is that we've got vascular genetic signals, but also got brain genetic signals from astrocytes telling us the importance of brain for stroke risk, not just vessels. So perhaps for us as neurologists, it's important.
Yeah, it's very political when we want to address also political issues of funding in our own countries. I mean, stroke is a brain disease, and we should really stick to that and promote that.
Thanks.
So also really interesting data about epigenetic clocks. So what's your take-home message there in terms of how do you gonna improve your biological clock?
So chronological age and biological age, they're actually quite difficult things. Chronological age we all understand. Biological age is much more difficult to understand as a concept, and you can think about it as a concept of aging of particular parts of your body, so vascular aging or muscle aging, where we can look at doing worse than you would do at that chronological age. But when you look more generally at biological age, you're often looking at increases in over-expected mortality. So really, and also epigenetics doesn't necessarily tell us about changes in protein expression, so it doesn't necessarily identify candidates. So I think that's very interesting, but it's there. I think this is within the prediction space, which may or may not be useful, is my kind of thought just now. But I'm sure there'll be exciting developments.
But also it helps us to understand that some traumatic in terms of body event goes beyond beyond the organ, so it affects more than your organ, just the brain. It affects a whole system, and we probably need to have more holistic approach to understand how one event in one single organ influence the whole body balance.
Well, indeed, actually influencing your DNA.
Yeah,
in
exactly.
Your blood.
So that I think that's really intriguing, and more to come from that side, I'm sure. Yeah. So maybe going over now to the trial which was presented, so the Interstroke trial. We have Charlotte here, expert in ICH. So maybe you can summarize what your take-home messages on from the trial and what we do and what are the next steps in this area. So Charlotte.
Well, I think the PI of the study told it, Professor Lehrer, we need to collaborate on that. Yeah. Because we think, well, it's an extremely frequent situation. We've got ICH with oral anticoagulant. We're going to be able to randomize. But in fact, it's 10% of 20% of a stroke. So it's rather a rare event in our clinical practice. There are a few things about the inclusion criteria that might be discussed about the long time window, what was 12 hours, and we know that everything is happening within the first 3 or 4 hours.
Yep.
But that doesn't explain the result of a study. The result of a study is that it has been incredibly difficult to randomize 67 patients within 5 years to either standard of care or standard of care plus tranexamic acid, which is a very cheap drug, easily available. And for the moment, all the studies on tranexamic acid have focused on ICH not related to oral anticoagulant. And there's probably a rationale for that, because we know that the hemostatic disorders associated with oral anticoagulant are quite strong. And you have difficulty to understand how fibrinolytic acid tranexamic acid as itself can influence the prognosis of those patients. But in fact, why only 67 patients? And you're from Switzerland, where the study was conducted. So is it because, I would say that in France, maybe sometimes the difficulty is that ICH is not always considered as a medical emergency. So you know the pathway of a patient goes there towards the surgical and surgically intensive care unit, while I think first of all it's a medical emergency, and then you just ask, do we need a surgeon? But not right away.
But exactly, I think that's one of the major hurdles also of the trial, and I think also that tranexamic acid at some places in Switzerland at least is even given off label. Okay. So sometimes it was not easy to be there and randomized first, and patients already got tranexamic acid. So I think that was also an issue.
Hematoma expansion is the right thing we should be targeting in the ICH trials?
I mean, if you want to identify a biological plausibility, maybe you can start by that. But I mean, we saw that when we target hematoma expansion, we always fail. I mean, all the trials have failed today. So is it because we don't have the right agent, or is it because we don't have the right target?
Exactly.
I think that the target is not the right one at present. So we desperately need to be all together on that. And also I was surprised that only 60% of the patients included received the standard of care, which should have been PCC or specific antidote. And I'm quite surprised about that, because it was within the first 4 hours. So I'm sure they were not already considered as with a DNR, DNR limitation. So I'm not so sure I understand that.
Okay. Probably moving on to one of the other topics today, perhaps I'll ask Will about the other lecture I found particularly interesting was the one on cancer and stroke in the young. And so given there appeared to be an increased risk, particularly in younger people, for cancer in the year after their diagnosis of stroke, did you think that evidence was indicative of a likely causal association, or do you think this was potentially just an association with finding?
Well, of course, we all know from clinical experience that every so often a young patient presents to us and we investigate them and they present either that time or later with cancer. So is this causal or not? Well, we've got a couple of suggestions. We've got some cancer, smoking-related cancers there, bowel and lung cancer, which we could see how that might have a relationship with shared risk factor of smoking. But the finding on hematological malignancies is interesting. So we were talking earlier, Mira, about hematological cancers and the increased risk of thrombotic events, and people have wondered whether that's due to clonal expansion. And clonal expansion has shown to have increased risk of atherosclerosis and other findings. So is this some kind of common risk factor here? But the effect size was quite large, I thought. So almost certainly there are other things we're missing. And so large-scale data like this is really useful to doing this kind of study where you wouldn't be able to estimate these associations in any other way. Gives us some hypotheses, I think, to go back to smaller studies or laboratory studies.
And what do you think? Do you think we should be, so if I'm in a clinical practice and I've got a young stroke patient and it's entirely cryptogenic, would you do you think this study suggests we should be screening for cancer more systematically?
So I think for that we needed some absolute risk estimates.
Yeah.
You know, what proportion of younger patients were at risk over, say, the next 5 years, when that screening is going to make a big difference. If they have a high proportion of having cancer 5 to 10 years, then my screening might not come up with anything.
Excellent. Thank you very much. I think we're at the end of our time for today. So thank you everyone for joining us, and particularly thank you to Will and Charlotte for giving us such great insights on the wonderful talks from